My name is Dr. Duvuru Geetha. I'm a nephrologist from the Johns Hopkins University School of Medicine. Today, I will be providing an expert perspective on the role of B cells in the pathogenesis of IgA nephropathy. IgA nephropathy or IgAN is a B-cell mediated kidney disease that is associated with a quartet of disease markers. The disease begins with B cells that are stimulated by cytokines, B-cell activating factor or BAFF, and a proliferation-inducing ligand or APRIL to produce an abnormal antibody called galactose-deficient immunoglobulin A1 or Gd-IgA1. Elevated levels of Gd-IgA1 are associated with greater risk of kidney function deterioration, end-stage kidney disease, and death. The immune response triggered by Gd-IgA1 results in the production of autoantibodies and immune complex formation with deposition in the kidney, leading to kidney damage that manifests as hematuria, proteinuria, and a decline in kidney function. Hematuria is a common clinical manifestation of IgAN and is observed in more than 70% of patients. Persistent hematuria over time is associated with an 87% increase in the risk of kidney failure. Several studies suggest hematuria is a potential predictor of progression to end-stage kidney disease, and there is evidence that resolution of hematuria may be associated with improved kidney outcomes. Proteinuria levels correlate with the rate of eGFR decline, and both measures can predict kidney outcomes for patients with IgAN. While patients with low proteinuria levels or low rates of eGFR loss are often considered low risk, they are still at long-term risk of progressing to kidney failure. An observational study from the UK Rare Disease Registry showed that even at low levels of proteinuria between 0.44 and 0.88 grams, 30% of patients will develop kidney failure within 10 years. The true prevalence of IgA nephropathy is not known because it requires a biopsy to diagnosis, and there are regional variations in the thresholds required for a kidney biopsy. The disease is most commonly diagnosed in young adults, but it can affect people of any age. Some patients will have episodes of gross hematuria, which is visible blood in the urine, but in many patients the disease may have no associated signs or symptoms. Gross hematuria may follow episodes of viral infection. Diagnoses of IgAN are often made incidentally when a patient visits their doctor and their urine is tested with blood or protein discovered on the dipstick. Because the disease is often detected incidentally and signs and symptoms don't occur until chronic kidney disease is already established, this can lead to late diagnosis when the patient has already sustained kidney damage and has chronic kidney disease or CKD stage 3 or higher. At the time of diagnosis, if late, patients may already have developed a certain degree of kidney damage that may not be helped by standard CKD treatment of blood pressure control and lifestyle modifications. Recent observational studies from large registries have shown that unless the rate of kidney function decline can be significantly slowed, almost all patients with IgAN are at risk of kidney failure within their lifetime, with many patients requiring dialysis or transplant in young adulthood. A study of patients with IgA nephropathy from the UK Rare Disease Registry estimated that approximately 75% of adults with IgAN will progress to kidney failure within 20 years of their diagnosis. Almost all patients under age 50 with the eGFR decline of 3 milliliters per minute per year will reach kidney failure within their lifetime. Unless the rate of eGFR decline can be lowered to 1 milliliter per minute per year, the average rate in the general population, patients with IgAN remain at high lifetime risk of kidney failure. The kidney damage that leads to this loss of function is often irreversible since our nephrons are not replaced over time. Our priority should be to diagnose and treat patients early in order to slow or halt the progression of kidney disease and protect as much kidney function as possible. IgA nephropathy is a chronic and progressive B-cell disease that carries a high lifetime risk of developing kidney failure, which has significant impact on patients because it requires transplant or dialysis. Patients are often diagnosed young, so this disease puts many relatively young patients on dialysis and carries a high socioeconomic burden. Kidney damage caused by IgAN is often irreversible, so it's vital to treat this disease early to protect as much kidney function as possible. While the current standard of care may slow eGFR decline, current treatment options are limited and do not prevent the eGFR decline that leads to kidney failure. New therapies that target the mechanistic source of disease are urgently needed to try to slow or halt the disease progression. The 2021 Kidney Disease Improving Global Outcomes or KDIGO guidelines recommend optimized supportive care as the first line of treatment for patients with IgAN. This includes blood pressure control, lifestyle modification, addressing cardiovascular risk factors, and minimizing proteinuria using ACE inhibitors or ARBs. In addition to this standard of care, patients are increasingly treated with SGLT2 inhibitors to prevent cardiorenal complications of CKD. There is evidence that using these approaches can delay the progression of disease, but patients receiving these treatments still experience a decline in kidney function over time that will eventually lead to kidney failure. Furthermore, many patients may respond suboptimally to these treatments and would need additional therapeutic options. For example, the DAPA-CKD trial evaluated the effect of the SGLT2 inhibitor dapagliflozin along with standard of care on kidney outcomes in patients with both diabetic and non-diabetic kidney disease. In a sub-analysis of patients with IgAN, while dapagliflozin resulted in better outcomes than placebo, treated patients still had an average eGFR decline of 3.5 milliliters per minute per year. With this rate of eGFR decline, almost all patients from an observational study of the UK Rare Disease Registry progressed to kidney failure within their lifetime. Currently, there are no approaches that are considered disease-modifying and target the immunopathogenic source of IgAN. Upstream of the quantitative disease markers of Gd-IgA1, hematuria, proteinuria, and eGFR decline, the disease starts with overactivation of B cells through signaling by the cytokines B-cell activating factor or BAFF and a proliferation-inducing ligand or APRIL. Targeting these pathologic drivers of IgAN and directly addressing the B-cell source of the pathologic autoantigen and autoantibody formation offers the potential to decrease immune complex-mediated kidney injury, which could slow the disease progression in these patients. IgA nephropathy is a disease of the kidneys, but it starts when B cells produce an abnormal form of IgA antibody called Gd-IgA1. Because this antibody lacks galactose residues from the hinge region, it is recognized as an autoantigen by the immune system. Anti-Gd-IgA1 autoantibodies combine with Gd-IgA1 to form immune complexes that deposit in the glomeruli, resulting in stimulation of inflammatory processes and glomerulonephritis. This manifests as hematuria, proteinuria, and eGFR decline and can eventually progress to kidney failure. There are two cytokines in this process: B-cell activating factor or BAFF and a proliferation-inducing ligand or APRIL. BAFF and APRIL are essential for B-cell survival, proliferation, and maturation, and also for immunoglobulin class switching to cells that produce IgA. These cells further mature into plasma cells that produce immunoglobulins. These activated B cells may originate in the mucosal associated lymphoid tissues. However, they may miss traffic to other systemic locations, including bone marrow, lymph nodes, and even the kidney. BAFF is critical for the maintenance of the B cell pool and also for the maintenance of the plasma cells that produce the antibodies responsible for IgAN. In preclinical mouse models, overexpression of BAFF has been observed to produce an IgAN-like disease, and treatment with anti-APRIL antibodies has shown reduced IgAN progression. There is evidence from multiple observational studies that BAFF and APRIL levels are increased in patients with IgAN. BAFF levels are associated with circulating IgA1 and kidney IgA deficits in patients with IgAN, and higher BAFF levels are positively correlated with increased proteinuria and reduced kidney function. Higher APRIL levels are also associated with higher serum creatinine, lower eGFR, and a worse prognosis in patients with IgAN. By blocking BAFF and APRIL, the stimulation of B cells can also be blocked, which significantly reduces the formation of the pathogenic Gd-IgA1. BAFF and APRIL have overlapping roles in B cell differentiation, and there is preclinical evidence that dual inhibition of both cytokines is more effective at inhibiting plasma cell survival and reducing proteinuria than inhibiting either cytokine alone. This indicates that dual blockade of both BAFF and APRIL may be necessary for maximal and sustained clinical efficacy, and this offers promise as a potential treatment for IgAN.